Okay.
So greetings and a warm welcome to all the dignitaries present here. I'm Srevshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Oncology Integrated Society, and the focus of today's session is Dysgerminoma in young unmarried. So now I'm going to play the Saraswati Vandana to give a warm welcome to each and everyone present in this webinar.
ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः हंसवाहिनी नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः हंसवाहिनी नमो
Hello.
So thank you so much everyone for your patience. Let's begin today's session, for which I'd like to invite Dr. Dipti Chaturvedi ma'am to take over.
Okay.
So, ma'am is the present member of executive body GOGS, GKP, past IMA, WDW Society, head of Gorakhpur, past executive member of UPIMA, WDW State Chapter, past scientific secretary of GOGS, past vice president of GOGS, past cultural secretary of GOGS.
Okay. बहुत बोल
Yes,
दिया.
ma'am. Over to you, ma'am. Please proceed with the talk.
Okay. First, I will give a welcome to all of you. Good evening, respected dignitaries, distinct faculties, esteemed panelists, and colleagues. It's a proud privilege to welcome each one of you to this academic webinar hosted by the OIRF and GOGS. Your presence reflects a shared commitment to advancing oncology care and redefining our approach to complex clinical challenges, particularly those that intersect with the quality of life and future potential. May I have the CV of our guest of honor, Dr. Uma Singh? It is now my singular honor to extend a most gracious and heartfelt welcome to our guest of honor, Dr. Uma Singh. Man, you embody a rare confluence of clinical.
नहीं नहीं वो देहरादून होगी.
All please mute. You embody a rare confluence of clinical brilliance, academic depth, and visionary leadership. Your illustrious career, marked by your stewardship as HOD and Dean KGMC, your association with global bodies like WHO, and your influential roles in national organizations stand as a testament to the unwavering dedication towards women health and gynae oncology. Your contributions to cervical cancer screening programs and medical education have not only shaped the systems but also have impacted countless lives with precision, compassion, and foresightedness. We are truly privileged to have you, your esteemed presence with us today. Your guidance adds immense intellectual and moral gravitas to this forum. I also extend a heartfelt warm welcome to our respected speaker, chairpersons, expert panelists, moderator, whose collective expertise promises a deeply enriching session. With this, I once again welcome Dr. Uma Singh, the guest of honor, for her pearls of wisdom for the whole webinar. Thank you, ma'am. Dr. Uma Singh, please.
Thank you so much. First of all, I must congratulate Dipti and Dr. A.K. Chaturvedi for starting this, whole integrated oncology platform because, there is no doubt that oncology, even though prevalent as a disease, um, somehow does not attract so many discussions, webinars, and conferences. And not just the gynae oncologists, but gynecologists as such often have this issue of not hearing lot of gynae oncology being discussed around. They also organize webinars which address all full spectrum of oncological management, that is diagnostics, that is surgical, that is radiological, and of course chemotherapeutic parts. That's the best part, that it really gives an integrated platform that way. So congratulations.
Thank you.
I am also very, very happy to hear a topic of dysgerminoma in a young girl being discussed today. We all know we have been hearing, and we do manage ovarian malignancies in elderly women, and there is fairly clear pathway and management protocols. But often in young population, ovarian malignancy still always is a challenge. Dysgerminoma is one of them. And especially we know that in young age, because not just the disease management is a challenge, but fertility preservation is an added issue which is not there in an elderly woman. And nowadays, with advancements in fertility sector, there are a lot of options which can be offered. And if we gynecologists and gynae oncologists do not have knowledge of this component, then once the treatment stops, there is no going back. And often the woman, the lady, the girl gets deprived of this fertility option. And also because management of ovarian cancers in young age also now has advanced to a stage where she can have a life, a fruitful life after treatment as a survivor, hence all these options. So I'm particularly very happy about it, and hopeful that after this webinar, many of us who are present here would be really enlightened by this aspect particularly. And you have chosen a wonderful speaker who has got a lot of experience, so everybody would be benefited. Thank you so much, Dipti, for again involving me, giving me this beautiful opportunity to interact, to see great friends, and that GRMC link always is close to heart, which for everybody, his own or her own alma mater is always special. So how much old you become, how many years pass by, but that link always is there, which is a soft corner for you. So thank you for reviving that element again and again. Thank you so much. Happy to see friendly faces, all my dear friends. Amrita is there, Pam of course is there, and happy to have you all. Best wishes, and please go ahead. Thank you so much.
Thank you so much, ma'am. It was wonderful listening to you and taking your blessings. Now, can I, with your permission, proceed further? Thank you, ma'am. Now, I would like to introduce the moderator, who is none other than my daughter, Dr. Diksha Chaturvedi. She is an oncologist. She has done her MBBS, MD from SRMS, AIMS, and after that, she has done her SRship in Bareilly, SRMS, and in AIMS also. And nowadays, she is working at our own hospital, Dr. Chaturvedi Cancer Hospital. She is trained in 3D CRT, RGRT, IMRT, VMAT, brachytherapy, chemotherapy, targeted therapy, and immunotherapy. And she has received awards from quiz and ICU care and quiz on prostate, neuro-oncology quiz, and she has had many oral presentation, poster presentation, and publications on various topics in conferences, international conference Dubai, and in the national conference AROICON New Delhi. And she has been student coordinator in nursing training workshop and teaching instructor in SRMS contouring classes. And she has had training in basic course in biomedical research. And the 13th AROI ICRO Clinical Radiobiology teaching course organized by AIMS Rishikesh, Uttarakhand. And she has had training in BLS and ACLS 2022. Over to you, Dr. Diksha, to introduce all chairpersons, panelists, and experts. Diksha Chaturvedi.
Good evening.
Online.
Good evening, all seniors. Thank you for the introduction, ma'am. I would like to introduce all the seniors. So starting with Dr. Sahana Punneshetty, ma'am. Ma'am is MCH and MS in Obs and Gynae. She is a consultant at Regency Hospital from April 2025 and also at Fatima Hospital, Gorakhpur. Next, I would like to introduce Dr. Shashibala Bhonsle, ma'am. Ma'am is a governing council member, ICOG 2026-2027, founder, president, Gwalior Menopause Society 2025-2027, chapter convener, Association of Medical Women of India, and national coordinator, IAEC, Committee FOXY 2022-2025. Welcome, ma'am. Would like to introduce Dr. Ayush Garg, sir. Sir is associate professor at Apollo Hospitals. He has done his MBBS, MD, and CCEPC, which is an Indian Association of Palliative Care 2018, clinical fellowship at Royal Marsden Hospital in 2022. His area of interest is head and neck cancers, gynecological malignancies, breast cancer, brain tumor, and palliative care. Sir has won many awards nationally and internationally and has many number of publications, both national and international. Dr. A.K. Chaturvedi, sir. He did his MBBS and MD from NG Medical College, Indore. Owner, Dr. Chaturvedi Cancer Hospital, Basharatpur, Gorakhpur. He is past president of UPROI and was trained at Memorial Sloan Kettering Cancer Center, New York. He has been a co-guide to many cancer theses at BRD Medical College, Gorakhpur, and has many awards and publications to his career. I would like to welcome Dr. Upma Jaiswal, ma'am. Ma'am is MBBS, MS, FC, FICM, CH, FICOG Fellowship Reproductive Medicine, Fellowship Cosmetic Gynecology. Ma'am is Chief Consultant at Swasti Marigold Multi Specialty Hospital, and presently she is Secretary of GOGS Society. Would like to introduce Dr. Aruna Chhaparia, ma'am. Ma'am is MS, Obs and Gynae, FICOG member, consultant and director, Chhaparia Hospital, past Secretary GOGS, past Vice President at IMA Gorakhpur. Ma'am has been Master Trainer at Foxy RAC and Master Trainer at Dhira. Special interest in high-risk obstetrics and infertility. Dr. Babita Shukla, ma'am. Ma'am has been ex-secretary, treasurer, scientific secretary of Gorakhpur Obs and Gynae Society, clinical secretary of ISOPAB, Gorakhpur chapter, organizing secretary, SAFOG Saving Mothers Conference 2019, scientific secretary, ISOPAB Conference 2021 and 2023, secretary of Women Doctors Association, Mission Pink, Gorakhpur. Ma'am has won many gold medals, has many poster presentations, also internationally. Ma'am is an active participant in national and zonal conferences as faculty. Dr. Amrita Jaipuryar, ma'am. Ma'am is consultant gynecologist obstetrician at Jaipuryar Medical and Research Center, Garg Hospital, Gorakhpur. Ma'am is president of Gorakhpur Menopause Society presently and past president of Gorakhpur Obs and Gynae Society 2021 and 23. 21 to 23. Secretary ISOPAB Gorakhpur Chapter India. Ma'am has been an organizing secretary in workshops of maternal mortality and in 2010 and many other paper.
It's okay, Diksha. Let's move further. Thank you.
Okay, ma'am.
I'm here.
Would like to introduce Dr. Rita Singh, ma'am. Ma'am is MS FICOG member and professor, unit head, Obs and Gynae Department, BRD Medical College, Gorakhpur. Would like to welcome Dr. Kavita Bapat, ma'am. Ma'am was Vice President, Foxy 2021-22, Director, Bapat Hospital, Indore, Organizing Secretary, AICOG 2022, Indore. Dr. Monica Singh, ma'am, President-elect Bhopal Obs and Gynae Society, Managing Committee Secretary, ISRAR, Vice Chairperson, MPSR, Academician responsible for starting and continuing Perfection Series, Symbiosis Series, Synergy Series. Dr. Nidhi Khetan, ma'am is MBBS MD, Consultant Obstetrician and Gynecologist, Khetan Multi-Speciality Medical Research Center, Gorakhpur. Ma'am is Treasurer, Executive Member of GOGS, Life Member of Foxy IMA, ISOPAB, Special Interest in Infertility. I welcome all my seniors to this conference. Thank you.
Hello. Yeah, now, am I audible or not?
Yes, ma'am. You are audible.
So I would now request Dr. Ayush Garg to introduce our speaker. Dr. Ayush Garg, please. Shreyasi, please put the CV of Dr. Swasti.
Good evening to all, and thank you to Chaturvedi sir and ma'am for giving me this opportunity to be a part of this academic event.
I can't see you, Dr. Ayush.
So it's my honor to introduce our speaker for today.
Dr. Ayush, please be visible. Hello. No problem, you can just keep speaking. अगर उसमें कुछ
He's
problem
lost connection, I think.
So anyway, we can introduce.
Am I audible?
You are audible, but you're not visible.
I think, ma'am, there is some
Okay, you can
network
just,
issue.
Mr. India, Mr. Guru.
disappearing person. He's from SRMS. Now he's in Lucknow, Apollo Hospital. Dr. Ayush, you can just keep speaking. We are
Dr. Swasti's CV is so loaded.
loaded. Dr. Ayush, please introduce her. Okay, Dr. Swasti is a senior director, gynae cancer surgeon. She is trained in laparoscopy and robotic surgery. She is in Max Institute of Cancer Care, Max Super Specialty Hospital, Vaishali and Patparganj, Max Multi Specialty Center at Noida. She has done her MBBS from SMS Medical College, Jaipur, DNB Indraprasth Apollo Hospital, MNAMS, member National Academy of Medical Sciences, and DIP ADV Gynae Endoscopy, Germany, and PGC MLS Symbiosis, Pune. Fellowship in Robotic Surgery, WALS, and Robotic Gynae Oncosurgery Training at Sweden. Convener of Delhi Gynae Oncology Group, and she is a member of Adolescent Committee, executive member of Delhi Gynae Forum, Southwest Delhi, and ex-member Oncology Committee, AOGT. She has had numerous national and international publications to her credit, and she is editorial board member and reviewer for many prestigious national and international awards. She has many accolades to her credit. Yes, Dr. Swasti, we would like to hear from you. The topic, ovarian dysgerminoma in relation to saving the infertility in young unmarried women, girls.
Thank you, ma'am, for your kind introduction. Are you able to see my slides?
We are able to see you now, it has come. Yes, thank you.
Make it full screen. It's
Yeah.
not.
Not able to do
Put a
that.
bigger
Why
one.
is that so? Full screen nahi ho raha. I'll share it again. Probably there's some problem with the
You
page.
can leave and again rejoin.
Hmm.
Then it will come.
Yeah.
Yeah.
So, good evening to all my seniors and colleagues. Thank you, Dr. Dipti, for having me here today. This is very pertinent to discussion. Once cancer in young women, there's a lot of apprehension in the family, and parents are very apprehensive. The girl is unmarried, what to do, how to preserve her fertility, what kind of good quality outcome of life we can give to her. So I'll be talking about ovarian dysgerminoma fertility preserving approach today, and I'll be presenting a case. And when Dipti ma'am called me about this topic, I had just operated a couple of days back a young girl with ovarian dysgerminoma. Very interesting presentation. As we all know that ovarian cancer is more common in postmenopausal age group. The median diagnosis is 63 years of age, but about 10% of them are getting diagnosed in the reproductive age group. Now, about 10% of all patients with epithelial ovarian cancers are less than 40 years and they've not completed their childbearing. So, when we talk about non-epithelial ovarian cancers, sex cord stromal are rare tumors of the ovary, first 2 to 3 decades of life. Adult granulosa tumors, have a peak incidence at around 50 to 55 years of age group. The germ cell tumors are usually in younger women and in early decades of life. And this is the case which I'll be taking you through. There isn't much to discuss, but I think there are just fine couple of points which we need to keep in consideration. So this is a 24-year-old unmarried girl who presented with the symptoms of abdominal pain since a few weeks, which was mild to moderate in severity, and she attained her menarche at 12 years. This is very important that we take a history of attainment of menarche. Menstrual cycles were regular. She had a period 10 days back. On examination, there were no supraclavicular nodes palpable. There was a large 36 weeks abdominal pelvic mass, which was firm in consistency, fixed, sharp borders, well-defined, non-tender lesion. On a rectal examination, the bulge of this lesion was felt and the rectal mucosa was free. So we did an ultrasound and there was a 20 to 15 centimeters mass. This ultrasound had already been done on her and she had been advised a contrast enhanced MRI of the whole abdomen in which the lesion was solid lobulated. You can see on the MR images very clearly a solid lobulated mass with central cystic areas with the largest dimension of about 20 centimeters. So usually whenever we, as a thumb rule, we image and we want to know about more about the lesion, we want to understand the nature of the lesion, and MRI is a better modality. And in younger women especially, we avoid using CT or a PET CT unless really necessary or indicated because we want to avoid radiation exposure. So we evaluated this lesion further and did all the spectrum of the tumor markers. The other markers were normal, including a CA 19-9, CA 125, CEA, AFP, and beta HCG, but LDH was very, very high. So it was about 10,051. This is quite high LDH. So looking at the spectrum of the tumor markers and the presentation on the MR, we were quite sure that it should be a dysgerminoma because that is how it presents, but still we wanted to be sure. So a detailed counseling of the patient and the family the parents was done, and the right ovary was normal. Or even on the MR, we could see a small right ovary, which was normal. So we gave her the option of a fertility sparing surgery by a midline vertical exploratory laparotomy. And it's important not to attempt these lesions through a fan and steel scar. A fan and steel incision is not a good idea in any of these malignancies, and especially whenever we are planning a frozen section when we are suspecting a malignancy. The whole idea is because we need to stage these tumors well. So she underwent an exploratory laparotomy, peritoneal wash cytology. We did a left salpingo-oophorectomy. This was a large lesion, quite adherent. The left ureter was very pulled up, and we had to dissect the entire ureter. We did a high ligation of the left infundibulopelvic ligament, and the frozen section revealed dysgerminoma. So she underwent multiple staging with multiple peritoneal biopsies, infracolicomantectomy, bilateral pelvic and retroperitoneal lymphadenectomy. Now, the interesting bit was that she had greatly enlarged lymph nodes on the left pelvic and the retroperitoneal. I had to go up to the left renal vein. They were 3 to 4 centimeters in size, not non-necrotic nodes. So the question was, could these nodes be positive? Now, in dysgerminoma, many of these women have malignancy, have a lymphatic involvement, and retroperitoneal nodes could be more involved rather than pelvic nodes. The right side pelvis was absolutely clean. So, this is how the lesion looked when we opened. You can see the transverse colon and the infracolic omentum with great vascularity, and it was all adherent to the lesion. So I did an infracolic omentectomy, and along with that, we did a ureteric dissection, and then we did a left salpingophorectomy. The other ovary, the right ovary and tube were normal, and the uterus was normal. I'm just pushing it anteriorly so that the ovary could be seen well on the right side. So there are certain concepts that we need to understand when we do this kind of thing, that we should not damage the other ovary if it grossly looks normal and there was no suspicion on an imaging. So this lesion weighed about 2 kilograms, and the idea, what defines a fertility sparing staging or FSS, is that only the uterus and the contralateral tube and ovary are preserved, and the rest of the things, the rest of the surgical detailing is similar to that in as in a staging surgery for somebody who doesn't want to preserve a fertility. So that means either you do a cystectomy or a salpingophorectomy, depending on the kind of lesion, on the kind of pathology, preserve the uterus, preserve the contralateral ovary and the tube, and do a complete surgical staging, which will include a peritoneal washing, abdominal cavity exploration, a mentectomy, multiple peritoneal biopsies, pelvic and paraortic lymphadenectomy. So the wedge biopsy of the normal ovary is not recommended because it defeats the purpose of a conservative treatment or a fertility sparing. What is most important is that these patients and their families, these women, are made aware of the fact that fertility sparing staging is not the standard of care. It is a deviation from the standard of care, and whenever they complete their childbearing and fertility, they should go ahead and get a complete site reduction done. So sometimes you have bilateral tumors in those situations where and they are large enough. In those situations, if it's not possible to preserve the ovary, then probably do an endometrial evaluation, do a hysteroscopy. If the endometrium is okay and a serosa is okay, then uterus can be still preserved for uh, later purposes. And this is as per the ESCO, ESHRE, and the SK guidelines 2024. So even the biopsy of the contralateral ovary is not recommended unless clinically indicated. So if you look at various epithelial and non-epithelial ovarian neoplasms, definitely where all can we do fertility sparing staging. So in all stages of borderline ovarian tumors, in stage 1A and 1C1 of low-grade low-grade serous carcinomas and low-grade endometrioid, and mucinous carcinomas with expansile invasion 1A, 1C1, and 1C2. Clear cell, yes, 1C1 is a little gray zone, but definitely 1A. High-grade serous, only 1A, confined to one ovary. High-grade endometrioid, 1A. mucinous carcinoma with infiltrative invasion, again only 1A. While if you look at the non-epithelial ovarian neoplasm, the germ cell tumors, you can do a FSSs in all the stages because they're highly chemosensitive. So even if you have a stage 4 tumor, you can go ahead and offer a fertility sparing staging. In small cell carcinomas of the ovary, which are extremely rare tumors, we do not offer fertility preservation. In granulosa cell tumors, again 1A and 1C1. In Sertoli only 1A, nothing beyond 1A. In Sertoli cell tumors, which are malignant, definitely none. So, sometimes, when you look at Sertoli cell tumors, 1C2 and 1C3 stages, fertility sparing data is actually very scarce. So it's very difficult to sort of take decisions. You have to individualize from patient to patient. So this is what it is. And FIGO 2021 fertility preservation guidelines say that for a stage 1 disease who want to preserve fertility, conservative surgery with a USO can be considered after intra-op inspection of the contralateral ovary to exclude involvement. And this is how we consent these girls. This is how we explain to them and their families that despite of negative imaging to the other ovary, we are still going to grossly inspect and base our decisions on that. So suppose you find small omental nodules, you find disease outside the affected ovary, then definitely it upstages and the patients do not qualify in epithelial ovarian neoplasms for fertility sparing staging. So either one ovary or both ovaries will be removed, especially in cases of borderline tumors, where a partial cystectomy or a partial oophorectomy can be considered in cases of bilateral lesions. Depending on which side is a larger side and a more involved side, one can take decisions based on that. Then again, acceptable fertility rates despite adjuvant treatments with chemotherapy have been reported. There are no higher adverse obstetric outcomes or long-term unfavorable sequelae in the offspring. And so many of my patients with non-epithelial and epithelial ovarian neoplasms have conceived and have had no obstetric mishaps. For all other patients, if the disease is spread and beyond 1A, 1C, 1, then of course a complete staging in cytoreduction, maximal cytoreduction is indicated. So dysgerminomas in particular are more common malignant tumors, germ cell tumors, and 30 to 40% of all germ cell tumors are comprising of dysgerminomas. Usually they present in less than 20 years of age, and sometimes even in pregnancy, you can see these germ cell tumors in 20 to 30% women. Now, the important thing why I said that it's important to take the history of menarche, because if women who've not attained menarche, that is, they are premenarchal, and an excel mass and having a dysgerminoma, basically you have to exclude a gonadoblastoma. You should do a karyotyping, and more than 50% of gonadoblastomas will be having a gonadal dysgenesis and will convert into a malignancy. And 10 to 15% of dysgerminomas can be bilateral. So, what is important is a multidisciplinary approach and an oncofertility team comprising of a fertility specialist, of the oncologist, of the referring gynecologist, all they are together, and the medical oncologist should be a part of this team to discuss the possibilities and the way forward. So in 2020, again, this was the ESMO clinical practice guidelines, but said fertility sparing treatment is not the standard of care. The accepted possibilities of impaired survival have to be explained. Sometimes frozen may not be that sensitive, especially in large lesions, and especially in lesions where morphology is not easy to make out, borderline versus malignant, and benign versus borderline. So, comprehensive surveillance and complete surgical staging must be followed after a family completion. So, how to follow these women up? We do a 3 to 4 months surveillance every first 2 years, then every 6 months for the next 3 years, and after 5 years every year for at least 10 years post treatment, and physical examination and ultrasound by a good radiologist. One could consider if there's anything abnormal, or especially if the preserved ovary shows any changes, go ahead and do an MRI and probably an annual MRI in cases of lesions in the contralateral ovary to understand whether they need intervention or not. Depending on what was raised in tumor markers prior to treatment, depending on that and depending on the histology and depending on the kind of the pathology, one could utilize the tumor markers for a prognostication of a follow-up. Like in this lady, we could do a LDH for a follow-up because this was classically raised classic dysgerminoma findings. Only when you have an extensive suspicion of recurrence, patients lost to follow-up, come back again after a while, and then you want to exclude metastasis, there are symptoms, chest issues, cough, other things, then you can go ahead and do a PET CT. We avoid giving unnecessary radiation exposure to younger girls. And during pregnancy, also, the surveillance must be to take care of the right ovary. The ovarian health of the preserved ovary is very important. And the follow up of tumor markers is left out in pregnancy because they will be erratically raised. Breastfeeding is recommended. It should not be discouraged in women who've been treated with ovarian malignancies. Now, when should you allow conception after treatment? So, 6 months after surgery or completion of radiotherapy, one has to do an ovarian reserve assessment. In this patient, also, we did an AMH, though she was unmarried, but we wanted to understand what was the baseline ovarian, which is normal and good. After completion of chemotherapy, we should wait for minimum 1 year to allow the lady to get pregnant. Specific washout period before conception is 3 months for tamoxifen, 7 months for the anti-HER2 like trastuzumab, etc. And for the standard chemotherapy of germ cell tumors, we ask them at minimum 1 year not to have a pregnancy. So, desire for immediate pregnancy, fertility sparing staging did not affect the possibility of unassisted conception. Um, they should attempt spontaneous conception initially for 6 months, otherwise beyond which they should see a reproductive medicine specialist. If the immediate pregnancy is not desired, they can be referred to for an oocyte or an embryo freezing, depending whether they have a partner or not. So I think this is important, that when should oncological authorization be granted to these women? So all patients with borderline epithelial ovarian or non-epithelial ovarian should be advised, depending on the age, stage, pathology, unilateral, bilateral localization, mode of surgery, then whether the patient received any adjuvant treatment or not. So after a borderline tumor, we don't see borderline tumors, we don't give chemotherapy, we don't give adjuvant treatment. So they can straight away go ahead and have a try for a natural or a spontaneous pregnancy after a fertility sparing staging. Low stage, you can immediately refer them for an ART. Advanced stage, you can offer an ART after complete resection if there were no invasive implants. Borderline tumors which are at higher risk of relapse, we will definitely go ahead and say to get an oocyte or an embryo preservation straight away. Epithelial ovarian cancers, 1 year after completion of treatment, negative follow-up, negative markers, negative imaging, they can be allowed to have a pregnancy. Early stage non-epithelial ovarian cancer, we can even allow at 6 months if they've not received any adjuvant treatment. ART can be performed after 6 months of a negative follow-up after fertility sparing staging. Regardless of the cancer type, patients should be advised that they're not limited to one pregnancy. So if they've had one pregnancy, I've had my patients who've had two pregnancies and they've completed their family, they should be encouraged and allowed to complete their family, because that is the whole purpose of a fertility preservation. So when you talk about first line treatment settings, fertility preservation methods, ovarian stimulation followed by egg retrieval. Now, usually when you know the other ovary is fine and you have a large lesion, you do not go ahead and stimulate those ovaries. You have to wait for the surgical removal, and beyond which, unless and until you have the whole staging, you whole picture, need for adjuvant treatment, we do not go ahead and stimulate the ovaries. So after all this is there, then we go ahead and do an ovarian stimulation by our reproductive team. In borderline ovarian tumors, particularly, we should not consider KRAS or BRAF or ER receptors should not be used as contraindications to considering ovarian stimulation. So I would just like to conclude by saying that dysgerminoma is by far the most common germ cell tumor. Fertility sparing approach should be considered in all stages of germ cell tumors. 10 to 15% of dysgerminomas are bilateral, and preservation of contralateral ovaries depends on intraoperative findings. Oncofertility assessment and care is required for conception, and that is actually the goal for fertility sparing. So, not compromising oncological outcomes and keeping oncological safety in the picture, these women should be allowed to live a normal life and should be allowed the benefits and the perks of motherhood. Thank you very much for your kind attention.
Thank
you so
you.
much. Yes, Amrita.
Thank you, Dr. Swasti. It was a great talk. And the best part was that you said patient should be first.
Yeah.
Of course, we should assess her stages, the stage of the disease, and then only we can decide whether fertility preservation should be done or not. It's a tumor which occurs in young girls also, even from 10 years to 30 years of age. So, yes, and it is more common in patients who have abnormal gonads, that is, patients with Turner syndrome, etc. So, and it is also called as ovarian seminoma because it resembles seminoma of the testis in males. And these are the few things which I wanted to add. And I just wanted to ask, how good is LDH in the assessment of these tumors? Whether it helps in prognosis or just the diagnosis, or what is the role of LDH in
So,
such
ma'am, in
patients?
this lady, we had LDH as 10,000. So, we were quite sure this would be a dysgerminoma looking at her MR and this. So, yes, in germ cell tumors, the kind of markers that will be raised gives you an idea. So, suppose you have an isolated AFP rise. Okay, you probably would think of immature teratoma. Why would
Teratomas.
otherwise an AFP rise in a
Gynoid.
girl with a solid looking lesion? Then if
HCG.
you have an isolated LDH or you have an endodermal sinus tumor, so those are the kind of things that you can look at. Prognostically, all tumor markers have a prognostic value. Rather than diagnosis, we use them for prognostication. That is why a baseline marker is always, assessment is always made.
Right, because for CA-125, they say that it is no
Not
prognostic
complete.
value.
So, ma'am,
So
even for
that's why.
LDH and other things also, they are, largely prognostic.
And the recurrence rate is also very high in these tumors.
Yes.
So most of them recur in a year, most of them recur in a year, 2 years. So
That is why it is important to do a very good staging and especially do not omit the retroperitoneal nodes.
yes, ma'am. And when we were students, not much was taught to us, but we were told that this is the tumor which is very sensitive to radiotherapy.
Yes,
I mean, that's the only ovarian tumor which is good. When radiotherapy was not advanced, when chemotherapeutic drugs were not so good as they are now. But yes, as students, we were taught that this is the only ovarian tumor which responds to radiotherapy.
Right.
So it's good to go back. I mean, we are not doing much of oncology, but yes, it's good to learn through you. Thank you so much.
Thank you, ma'am.
Yes. Would you like to add something, Dr. Chaturvedi?
Yes, very nice to hear from Dr. Swasti and Dr. Amrita. And what you were telling us, radiotherapy, regarding radiotherapy. Nowadays, it is not used, it is used in the later stage. That too, when the fertility is not the matter. It's not the question. So in early stage, surgery number 1. Then if it is stage 2 onwards, you can go for the chemotherapy, chemotherapeutic reduction, then again go for fertility preservation, go for surgery. And if fertility is not a question, then go for radiotherapy. So that's the thing which is important nowadays. Latest drug, they have come, but the older drugs, BEP schedule, they are very sensitive to BEP. They melt like seminoma.
बीईपी regime थोड़ा बताइए. Hello, Dr. Ayush, are you there? What has happened?
We are not
It is
seeing
BEP is bleomycin, etoposide, and cisplatin-based combination drug. Regime
that's giving very good result. Right now, we have put one patient on this, so they are responding very well. And thereafter, you will go ahead with the radical therapy.
Can I add something?
Sure.
Yes, yes. Welcome, Upma. आ गई तुम?
Yes, ma'am. Ma'am, I would like to say that it is also written that if cisplatin has ovarian toxicity maximum. So in very young children, it is generally given JEB, bleomycin, etoposide, and carboplatin, because it is said to be less toxic than cisplatin.
In children.
Yeah, but the cisplatin which we are using is in quite a low dose.
It's preferred over carboplatin.
But yes, carboplatin is better for such people.
Anyone else would like to add something?
Ma'am, I would like to add something. I just wanted to answer Ma'am Ma'am's query. Like in seminoma test, like in seminoma testis, there is role of markers like beta HCG, LDH, and AFP. They are actually used in staging purposes. Maybe in future, in terms of research, maybe that they'll include in the staging of ovarian malignancies in future, but currently it is used in testicular malignancies as a part of staging, apart from TN.
Here it is LDH which is important. Rest of the tumor markers, they come nearly normal if it is showed Dysgerminoma.
Yeah, so I think so it has more of prognostic and follow-up में ज़्यादा जरूरत होती होगी ना कि recurrent तो नहीं हो रहा है.
Yeah, they should be closely follow up. Dr. Swasti?
Yes, sir.
Yeah.
Absolutely.
Where is Dr. Ayush? We are not hearing him. He is a very good radiation oncologist, senior consultant at Apollo. Are you there or you have left? I think so. He's not there. He has left.
Of recurrence is more with Dysgerminoma. One ovary you have sacrificed, they will develop another second ovary. So that's very difficult to treat those people.
And what do you do in recurrent ovarian dysgerminomas? Recurrent or the last stage?
Again, surgery and chemotherapy.
नहीं कुछ और भी बताइए.
Because recurrence are also very
No,
sensitive.
it is second line. There is a second line chemotherapy for it. It is TIP. That has, if patient does not respond to first line, we have to do complete surgical staging again, and then TIP is a second line chemotherapy.
Second look, laparotomy, and then the drugs have to be changed.
Yes, TIP is
imatinibs or something.
It follow-up is around 3 monthly.
What about
in first 3 years?
pembrolizumab and oral parib?
What about no role in germ cell tumors?
No role.
No role in germ cell tumors.
Okay, no role. मैं भी सुनती रहती हूँ इसलिए सोचती हूँ.
Role of what, ma'am? Pardon, ma'am?
अरे ये monoclonal antibodies.
No.
इसमें नहीं है.
That is not required.
Okay.
Very chemosensitive tumor. That is the best part.
Chemosensitive है तो you
chemo and radio.
Both chemo and radio sensitive, which
So
seems like it just melts away.
But radiotherapy is not recommended in fertility.
Because of fertility sparing, radio is not recommended.
Yes.
Otherwise, it's very sensitive to both.
Though it is very sensitive. So if she has completed family, then you can go ahead with radiotherapy. that is supportive. In case you don't complete the surgery properly due to adhesions or any other factor, then you can add
For
up
us
the
gynecologists, I
Ma'am,
think
query
if
for
we find a solid
Chemotherapy
ovarian
In the
tumor in a
stage
young girl,
stage
was
one,
chemo.
it is said that in stage one, it is said that
Surgery.
it is
the
surgery.
survival rate is almost 100% if
Yeah,
diagnosed
surgery.
and
Almost.
treated properly.
And,
Yeah.
and in stage 1A, we should not hurry for chemotherapy.
Yes,
We are
yes.
not
We should
giving
we should do the follow up, and we should not hurry for to start the chemotherapy.
You're right, absolutely.
And
Swasti ma'am, I have a doubt.
and
I
during
have a
surgery,
query for Swasti ma'am.
biopsy
Hello.
of
Bolo
the
Shana.
Yeah.
बहुत देर बाद
Ma'am,
बोली.
Swasti ma'am, I wanted to
Yeah, sure.
ask because this patient was 24 years. So the like girls who are like below the age of 20, like we
Hmm.
had two groups. One was like thoroughly they wanted to stage with complete lymphadenectomy, and there was another group of doctors who always wanted to do only if they were enlarged. So, what in your opinion for a adolescent or a girl who is less than 20 years and normal looking nodes after opening the retroperitoneum? So, do
So
you still
look,
proceed with systematic
so
lymphadenectomy or
see, I am a
only
propagator
enlarged?
of systematic lymphadenectomy. If we talk
Okay.
about ovarian dysgerminoma, their incidence of retroperitoneal recurrence is very high. This
Yes, ma'am.
girl had huge lymph nodes. I mean, I was actually thinking that maybe one of the nodes could be involved in this.
Uh-huh.
She had a complete chain of involvement from the left pelvic, common iliac, up to the left renal vein, the last node that I looked. And in fact, post-op, there was some amount of chyle also in the drain, which settled with a low-fat
Okay.
diet. I mean, it was that
Uh-huh.
extensive lymphadenectomy that I had to do.
Okay.
Now, suppose the lymph nodes were not enlarged. Even then, the plan was to actually remove at least the bulky nodes. Suppose they were
Yes,
normal
ma'am.
nodes. Suppose they were
Yeah,
there was
I wanted to
obviously
ask
tissue.
in normal
Yeah.
looking. Yes, ma'am.
Normal looking nodes also you should do staging. The idea is suppose any disease is there in the retroperitoneum, this girl will need chemotherapy. So how will you
Hmm.
decide? See, imaging
That
is
is true,
not
ma'am.
telling you
Because
anything.
studies, yes,
And
ma'am. It
tumor
the
numbers are
studies
very
were
high.
in favor, but they showed that it didn't have effect on overall survival. So we had a
No,
group of doctors who
that is
didn't
mainly for
actually do it.
epithelial ovarian. In dysgerminoma, now what is happening is your chemotherapy is going to get decided by this. There are no
Yes.
studies in the germ cell tumors. So there is no comparison between systematic lymphadenectomy and as a gyne-oncologist, it's very difficult to do only node sampling. I don't know how one can do node sampling.
Yeah,
It
true,
and
true, ma'am.
how you will decide which node you will pick up and where you can miss a micrometastasis. Because if you miss a node in this girl, now she will have a big retroperitoneal mass and she will come back in a couple of months
Hmm. Yes,
because
ma'am.
because this is a very very chemosensitive tumor.
True,
So
ma'am. Considering that chemosensitive, a few
and
doctors they used to
there is
support
no
them
head on
saying
comparison,
that
there is no trial
yeah,
which compares
yes, ma'am.
systematic lymphadenectomy to no lymphadenectomy or selective lymphadenectomy
Hmm.
in germ cell tumors. So there
Yes,
is
ma'am.
only isolated data and case reports to review.
Okay, ma'am.
When I
And
review,
routinely you do it up to infrarenal, ma'am,
yeah,
even for a normal looking all the.
yeah.
Okay.
I
And
always
also
do.
I
See,
wanted to,
because this is staging. See, in
yes,
staging,
ma'am.
you should
True.
do systematic lymphadenectomy. Now, when I, last couple of cytoreductions, I think last 4 years after the Lions trial came, many
Hmm.
people abandoned after a single
Yes.
trial, they abandoned doing systematic lymphadenectomy. The advantage they feel it saves time, patient is already
Hmm.
compromised, post chemotherapy, more
Hmm.
chances of infection. But I still don't practice Lions trial. I still do systematic
Okay.
lymphadenectomy. And believe me, in most of these patients where, see, Tata did studies and they showed that post NACT, most of the nodes are taken care of. The rest will be taken care of by adjuvant
Hmm.
treatment. But those will be sanctuary sites for recurrence.
True, ma'am.
And that
They
is, see,
might have those
why are
cells.
we doing, okay, if the omentum is normal looking, why are we doing omentectomy? Why are we not leaving the omentum behind? Because omentum is a sanctuary site for peritoneal disease.
Yes.
But that doesn't mean we do complete peritonectomy when peritoneum is not involved. Same
Hmm.
principle applies.
True.
Right. Now, when you are comparing in Lion's trial, when you're not doing systematic lymphadenectomy and you're leaving those nodes behind, those are the areas which actually harbor recurrence. You can actually follow up your patients and start, collecting your own data and introspecting. Now, when you take out those nodes, out of 25, 30, 40 nodes, one or two will erratically be positive. How will you decide on table which node will be positive or which node has residual disease? That is, there is no way to isolate a single cancer cell going across our body unless and until we have some test which or imaging which tests us or tells us a single node which is going to be positive. So out of a chain of 46, 48, 50, 70 nodes, if two are positive, then that means you've removed disease. That means it's a part of your cytoreduction. So that is why I personally don't believe in Lion's trial.
Okay.
I
No,
do
Nice.
one
systematic
more thing they
lymphadenectomy
said,
for all interval debulking.
normally they say that
Ma'am,
you have to remove the whole, means like suppose it was not
lymphatic chain.
fertility sparing, then you have to remove the
And
whole of
particularly dysgerminomas are very notorious. They are very notorious for retroperitoneal recurrence.
Location.
And in this girl we had, I mean, obviously you feel up because you open the retroperitoneum, go so high up, you feel morbidity will increase, whatever. But when you have large nodes, there is no way how you can, control that.
So for that, there's chemotherapy.
So at least if we stage and we remove the nodes and we know she's stage 3, now we are confident that we are not giving a chemotherapy because she's 1A. So that is the entire purpose of doing, she's stage 1A.
1A,
Nodes are negative.
Nodes are
All nodes were
negative.
negative. And at the moment, like in breast, there are so many times when they tell you a sentinel node is positive or not. So when a sentinel node is negative in breast on frozen and finally it comes out positive, they go back ahead again inside and they do a axillary clearance.
Second
That doesn't
operation.
happen in gynecological malignancies. In gynecological malignancies, we do ultra staging. We say one node is positive, fine, leave the entire chain of nodes. But I have had patients of endometrial cancer where I have done 3C2 optimal, complete debulking, 4, 4, 5, 5 centimeters, necrotic nodes missed on imaging. And till date, patient is alive, no recurrence, 9 years, 10 years. These kind of patients, it does affect survival. And every study, again, at the end of the day, says that when you're removing bulky disease, it affects survival. It improves overall survival. So that is definitely there. The question is, how do you identify which node you will remove and which node you will leave behind? That is the trick part. That you can't decide on table. Na? So either you take out all or you don't do.
Okay,
Yeah,
You just
anything
do
that is true,
sentinel and
ma'am.
come out. But for a high
radiotherapist
risk
people would like
disease,
to add?
Thank you, ma'am. And one more question, ma'am. In case of bilateral ovaries involvement and if the oophorectomy was done, do you prescribe them hormone replacement?
so depends on histology. If in borderline
For
tumors or
germ cell, it's done.
endometrioid in germ cell.
In germ cell, I'm
So
asking. For
germ
in this
cell,
case.
germ cell in this case, so no need, na one ovary is there.
No, not for this
Suppose
case, ma'am. I mean, this
bilateral are there,
germination.
Bilateral pushing.
we will still try to conserve the smaller side. Suppose one cyst is 20 centimeters, one lesion. The other ovary has 5 centimeters. So we will try to preserve some
Okay.
part of the contralateral ovary which has a
5
smaller
centimeters.
lesion because they are highly chemosensitive.
Oh.
So
You
we
can
will
say.
still try to preserve. Borderline also same principle applies.
Yes,
Suppose
yes,
you
ma'am.
have a
No,
say
just for germ cell, I wanted to know like whether in case there is a case where both the ovaries are involved and you're not able to save even a part of the ovary.
okay.
In her post-op hormone replacement, because she's too
Mm,
young. She's too
she's
young
too
to
young.
still.
Yeah, we'll have to give na hormonal nahi to.
Like we had
Abhi kuch
patient and
jaldi nahi.
she didn't have both the ovaries. We had put her on 21 days pill so that she at least gets her menses.
So
As a
what I
germ
can
cell.
say is that in germ cell
And a
tumors, if
youth.
you've had to remove both the ovaries,
It's
uh,
it's rare, ma'am, but still.
Hota
Uh,
hai, hota hai.
So suppose अगर
Just in your
bilateral,
experience, I wanted to
I'm
know.
just thinking अगर bilateral ovarian involvement है तो 1B हो गया,
हाँ
तो कीमोथेरेपी
हाँ
तो
मैम,
मिलनी है. छोटे वाले
बिल्कुल
उसमें
मैम.
डिजीज छोड़ दो. स्टेज 4 में भी तो आप डिजीज छोड़ते हो. स्टेज 4 में भी तो recommendation is that you leave, you know, you don't have to resect everything. It will just melt.
Or kind of do NACT and then go for surgery
Then you will not have
to
much to
preserve.
operate.
Yeah.
It will just disappear. I saw a patient operated in Lucknow, and this
हाँ
girl
मैम.
had germ cell tumor.
जी मैम.
They just went ahead and gave her chemo, and it just disappeared till date. Germ cell tumor was only based on a tumor marker analysis where AFP was high. There was no biopsy, no nothing.
See.
And now there is nothing ever to prove histologically what she had. There is no histological diagnosis. So post 3 cycles of BEP, there was no disease. Post 4 cycles.
Okay.
This is important question. If you have more than stage 1, means 2 and onward, now how will you diagnose if you don't take biopsy? And this
That
the
is
same
what it
problem.
is. I've
Yes,
seen
same
patients
problem. This is very
only based
important
on
question.
tumor. Yeah, without a biopsy, one
How
should
can
not
you
go ahead
treat?
and do it.
Yes.
But it is being done, sir.
कर रहे हैं मालूम है.
This is
कर
तो
रहे हैं लोग.
लेप्रोटोमी
And
बायोप्सी
this you have
देते
to
हैं
take a
और
chance. You have to
लेप्रोस्कोपी
take a chance
बायोप्सी
to
देते हैं.
biopsy the tumor.
Yes.
Whether you go directly or you go through
Or you do
the
by
tissue,
surgery. So
whatever
I'm
it is.
just thinking, suppose you have a bilateral lesion and the contralateral ovary has a smaller lesion,
माला
3-4
तो उसको बचा
centimeters,
लो.
leave that lesion behind. If it's a
If
germ cell tumor.
if you are leaving the lesion behind, that means it is going to
Recur.
increase.
नहीं sir, germ cell में तो कर सकते हैं ना. She is asking about germ cell.
Yeah, in germ cell I'm asking, not
Germ
epithelial,
cell,
sir.
germ cell
Germ
में
नहीं
तो
cell.
कर
पर
सकते
जर्म
हैं.
सेल में भी तो रिकरेंस ज्यादा है ना डिसजर्मिनोमा में.
मैम जैसे इमेच्योर टेरेटोमा है मान लीजिए, तो
हाँ.
दोनों ओवरी निकालने से तो बेटर है ना. डिजीज मेल्ट हो जाएगी. कीमो तो वैसे भी
Yeah.
दोगे ना 1A के ऊपर.
Yeah, you will be giving.
You will anyway give chemotherapy. So probably a 3-4 centimeter, 5 centimeter small lesion, do not remove the ovary. Stage
So-
4 में भी तो आप सारा ही छोड़ते हो ना. आप liver disease है, सब capsular है, peritoneal है. We've seen so many patients. Stage 4
Yeah.
में आप, you
Anyone
don't do
else
complete
would like to add
cytoreduction in
anything?
germ cell.
उपमा
Immature
यादव
teratoma में इसमें कहाँ
क्या
करते हो
बोल रही
आप?
हो
Stage 4 में तो fertility preserving करते हो ना.
Kind, yeah.
She
You
has
don't go
written,
ahead and do a liver resection.
Dr. Upma Jaiswal has written, in GCT, you can leave the small ovary. GCT. Upma, are you there?
My ma'am is there.
Speak up. Maybe it's not working. What do you mean by GCT?
Germ cell tumor.
Okay. So you can leave the small ovary. You can do partial resection also. Madam पहले ही बोली है ना.
हाँ.
Dr. Swasti has
Partial
already-
resection, cystectomy, मतलब जो भी है, the smaller, maybe a part of the ovary can be still
Whatever
removed.
healthier ovary is there.
Yeah.
Okay.
Leaving behind a very large ovarian tumor also is a problem. She can have torsion, and you may have to go back in again and operate. That I mean, torsion of a malignant immature teratoma is a possibility always. They are heavy tumors. So you have to
can we
individualize
conclude?
everything.
Thank you, ma'am.
Thank you for all for your active participation, Dr. Sahana, Aruna, Babita, and Ma'am Uma Singh. Ma'am, would you like to say a few words in the end? Ma'am Uma Singh? She's there online or not? Yes, she's there online.
That is creating a problem.
So no, it's been a very, very fruitful discussion, and there is no doubt about it. There is no single answer to any question. These are all individualization you have to do according to the patient, according to the size, according to the type. But yes, as you proceed, as advancements come, you learn them, you adapt them, you kind of work on them, and further evidences tell you whether this is the correct way or not. However,
no.
yes, these are the challenges which occur and we have to deal with them. It's been very good discussion. Swasti, you have made things very clear that when there is a young girl, how you can go about it and thereby give her the best possible chance of fertility and the best optimization of the disease management also. Thank you so much to the speaker, to the chairpersons, and of course the organizers,
Thank you,
Dipti and
ma'am,
Dr.
so much
Chaturvedi.
for
Thank
your
you.
expert
Thank you, ma'am.
guidance and expert views, opinions. Thank you, ma'am, so much for being here with all of us. It's an honor and privilege for us to have you here. Thank you so much, ma'am. Yes, any last words, Dr. A.K. Chaturvedi?
Thank you all and for the nice deliberation. And Dr. Swasti, as always, you're good. It's
Yeah,
very good to listen to you. And
it
everyone
has
has
been really
nice.
insightful and thought-provoking.
Yeah.
And the diversity
Thank you
of the
so much.
perspectives presented here reflects not only the depth of the subject, but also the analytical rigor and intellectual activity. So today's talk was a testament to our collective pursuit of clarity, truth, and progress to medical science, gynae science. It has contributed to a more nuanced and holistic understanding of the topic at hand. And now I extend my sincere appreciation to our speaker for her articulate, well substantiated, and persuasive contribution, which reinforced the importance of critical inquiry, respectful disagreement, and evidence based reasoning in shaping informed opinions. So it is truly fostering a spirit of intellectual curiosity and collaborative learning. Thank you, all the chairpersons, participants, experts, speakers, and clarinet. Thank you for your
Thank you, ma'am.
unseamless support. Thank you.
Thank you, ma'am. Thank you so much, everyone, for giving us the
Thank you,
opportunity to host
everybody.
the session.
I will see
Thank
you
you so
again
much,
in the
ma'am.
next meeting. Thank
Sure.
you.
Thank you.
Okay,
Good night.
Good night.
okay, good night.
Bye.